Maria, thank you for inviting me to do this. I met Bob+Sang, but I didn't know him, but I know him by reputation and feel pleased and privileged to speak in his honor. What I'm going to say is, I doubt what you've come to hear, but tough. It's what I'm going to say. It's a little bit flying a little higher than perhaps you may expect to. I'm not going to get into the bowels of systems of engaging patients. I'm going to ask some rather more, to me, more profound questions about what it's all about, it being the delivery of healthcare. And I'll try and weave in the theme of where patients fit into this, since after all it's supposed to be about patients. But I'll do it in the context of some things I'll offer you, some of which I think you will not be terribly pleased to have them offered to you. But we'll see. So, there's a titivating way of drawing you in, isn't it? And Phil Hammond is here, so I expect to read everything slightly readjusted in another publication with a not intruded whenever it should be, and so on and so forth. NOT rather than KNOT. So, what I'm going to do in the lecture is, if you like, consider the place of patients in healthcare. I haven't got any slides, by the way, so you've got to listen. And how best we can ensure that they get the care and they get the respect to which they're entitled. And notice I'm going to be talking about healthcare. There's another conversation for another time to be had about the place of the public and health. And when I'm interested in healthcare, welfare, all of that. But I'm talking tonight about healthcare. All right, to start with, when you get a discussion about healthcare, the story, by and large, has been one of a growing recognition, indeed advocacy, of the need to involve patients. Lots of reasons given. One is a pseudo-scientific one, that it improves the progress or the outcome of their care. Another is a rather benevolent notion that it seems like a decent thing to do. But for whatever reason, there's this growing sense of the appropriateness of involving patients. And this recognition of this notion has gradually grown into the rather more powerful notion of the right of patients to be involved. Not just that it's a good idea or they ought to be, but the right of patients. And as we all know, the language of rights spooked quite a few people when it appeared on the horizon, particularly healthcare professionals, a bit spooked by this language. They're very comfortable with the notion of professionals having a duty, but talk of rights was a bit too much in your face. If they could still talk about duties, it meant that they were still in control. That's the discourse over there. At a political level and at a policy level, things have gone even further from recognition of it's a good idea, notion of rights, policy level. We've now seen the embracing of involvement, empowering of patients, the embracing of the notion even of a general notion of rights. But we've also seen what looks like the right of the patient to be in charge. A patient-led NHS was the Labour Party's contribution to the discourse. Nothing to me without me is the present government's slogan. You'll be familiar with it. Now, if you stay with this rhetoric that we've moved beyond rights, encouragement of involvement towards a notion of rights, towards a notion of being in charge, if we stay with this rhetoric, it's important not to get silly. Patients can't lead the NHS. In many ways and in many contexts, they haven't a clue what next to do. Why should they? And to suggest to professionals that patients are leading is to get up the nose of the professionals inappropriately. Okay, you do the operation then. Equally, patients can't be involved in everything that's done to them. Nothing to me without me. Again, it's dangerous if the rhetoric is allowed to get silly. They can't be involved in anything done to them. Very often in hospital, they're unconscious, and in many other cases and contexts, they are the recipients of expertise over which they have no expertise themselves. So the rhetoric is in danger, and that's the rhetoric that you and I are all affected by, is in danger of becoming silly. It runs the risk, therefore, of being dismissed. Babies go out with bathwaters. It's in danger, the whole idea of involving patients is in danger of being dismissed for what that was, rhetoric. The underlying, if you like, philosophical point, the underlying cultural point about the proper place of patients in the discourse of healthcare, in the transaction of healthcare, gets lost. So I have to be careful. But having said that, at least at the level of discourse, at least at the level of conversation, there is this gradual movement towards recognizing that healthcare is about patients, and that their needs, their aspirations, their preferences, their fears need to be accommodated to the greatest extent possible. That's the discourse, that's the rhetoric, that's the conversation. Now, ladies and gentlemen, next step is to turn to the reality. What really is happening? What about what happens in the surgery, in the clinic, in the hospital, up and down the land? Notice I'm referring to surgeries and clinics because so much of the attention of the National Health Service and those who design it and those who lead it and those who comment upon it is directed towards what goes on in hospitals. But in terms of what patients encounter, neutral term, the GP surgery and by default the A&E department are where the large part of the action is, if not the drama. And I say the A&E department by default because, as you know, we have in England under the NHS an interesting health-related concept called out of hours. GPs have their regular service and then what's called out of hours service. It's always been intriguing. I'm not medically qualified, but it's always been intriguing to me to have a notion of being ill out of hours. I didn't know there were ordained hours for being ill.